It's Sunday, the 19th of July, 2020. This is the Synthesis Podcast with me, Howard Feldman, and COVID expert, Dr. Anton Meyberg. We do not have a vaccine. We do not have a cure. This according to South African Health Minister Zweli Mkhize. Our ability to break the cycle of infection depends on our willingness to remain focused and disciplined and take non-pharmaceutical interventions seriously. We can beat this pandemic together. So says the South African minister. Dr. Anton Meyberg, a very good morning to you. You look a little bit calmer this morning than you did last week. Last week, you were just more than a little frazzled. And I believe that by the end of the weekend, you had around about 42 serious COVID admissions. Tell us how we're doing.
So good morning. Yes, it's amazing what a few hours of sleep can do to actually calm the mind down. So currently we're sitting on 14,431,540 cases worldwide, with 604,984 deaths and 8.6 million recoveries. Unfortunately, South Africa is now in the top 5 of the world odometer for positive cases, sitting at 350,879 cases with 4,948 deaths. Gauteng is sitting on 5,748 cases in hospital at the moment, with 520 in ICU and 257 currently ventilated. There is still beds available in Gauteng. The numbers do turn over. A lot of the hospitals are not actually closed at the moment and are accepting new patients, but this turns around on a day-to-day basis. There is bed availability, like I said, and there is oxygen at this point in time, so things are looking a little bit more positive than they did this time last week.
Is there more oxygen available because there's less oxygen needed, or are we managing to keep up?
So I think at the moment we managed to keep up. This is a worldwide shortage. It's not just a country shortage. All over the world, people complain they don't have enough oxygen. And basically what happens is that the oxygen companies deliver oxygen to each hospital every 2 or 3 days to replenish their stocks. But the amount of oxygen we're using comparative to normal this time of year is dramatically increased. We could be using over 1,700 liters of oxygen a day compared to 1,000 or even less than that generally a day. And that's dramatic.
South Africa and certainly Gauteng has seen a tremendous amount of load shedding in the last week. How did that impact on people that were on oxygen?
Well, that's dramatic because if you don't have an inverter and if you don't have a generator, that's a big problem because you need the oxygen. With most oxygen run on what we call oxygen concentrators, which are connected to electricity and can deliver anything from 3 to 10 liters of oxygen. You need the electricity to power those oxygen concentrators. So if you're oxygen dependent, you end up in big trouble and you may have to be readmitted to hospital because you don't have oxygen being supported at your house.
Very, very serious indeed. Very, very alarming. All right, let's just take a look at some of those numbers that you were referring to. How concerning is it that South Africa is heading towards the top of the table? Was this expected given the size of our population? Is this a reflection on the fact that we aren't managing the disease properly? What are your thoughts around this?
So I do think we expected the numbers to go up. We did know they were always going to go up. We know because of the density in places like Alexandria and all those areas that the numbers are going to go up. And with all due respect, if you allow full capacity taxis to travel around the city or around the country with people inside them, we cannot not expect the numbers to go up. There's not enough mandate for the military or the police to stop these type of things when the government gives carte blanche to everybody to do this type of thing. So we can't control it from that point of view. So yes, we are expecting numbers to go up further due to the fact that we are not in control at this point.
On average now, we're seeing around about 13,000 plus new cases every day confirmed in South Africa. This is the number that you thought we would be at in terms of all of our conversations. Do you foresee this going much higher?
I really hope not, but the potential is there. It could even go up to 15,000, and I hope not much higher than that because I don't think we'll be able to manage that. At this point right now, we are semi-managing, although a lot of the hospitals are on breaking point. If you look at places like the Eastern Cape, they're not managing at all. In Gauteng, for now, we're managing, but if the numbers go much higher, we will not manage again. So we're hoping that this is sort of, in inverted commas, a mini plateau, or we're hoping that the peak is coming much sooner than we think because it's a major surge and it's doing dramatic damage to all of our hospitals, to our healthcare workers, and to everyone treating these patients.
The Eastern Cape, obviously a major concern. It's now been featured internationally in terms of just how shocking and difficult the situation is there. Are we, I mean, I know that Gauteng is barely managing. Do you think there's anything that we could do from these areas to assist?
It's a very difficult question, that because we're barely managing on our own. We've got to have certain amounts of oxygen. We've got to have certain amounts of beds. It's all about staff. It's all about healthcare workers. It's about nurses. It's about auxiliary staff. If you don't have the staff to manage the hospitals, then you can't manage the hospitals. So you can't go and send your staff down to the Eastern Cape, because then you'll be depleted at the same time. So from a humanitarian point of view, there's plenty we can do as a community, as a people. But from a medical point of view, you cannot deplete your own staff, because you're going to need them here when it gets up higher.
All right. As we've done every week, we've invited questions from our viewers. We have a tremendous amount of questions, as always. Again, we've grouped them into different areas. What I have noticed, and what is fascinating, is that many of the questions this week, and this is a trend that is starting to increase, have come from people who have been COVID positive and who are recovering. Lots and lots of questions around how long this is going to take. How long will it take for their smell and their taste senses to come back? What about fatigue? People sound tremendously fatigued. One of our viewers says he's got this dry cough that just won't go away. Is he considered still to be infectious? Is he, how long is this going to go on for? So I sense a fair amount of maybe despondency from people who have had COVID that thought by now the worst of it, or maybe the worst has passed, but it's definitely lingering and having a great impact on them. What are your thoughts around this? What advice, or what do we know about the behavior of the virus?
So at the end of the day, we still know nothing about this virus. This is a novel virus. We are still learning on a day-to-day basis. Every single day we learn something new about this virus. What we are seeing in people who have been infected and people who are recovering, it does take a long time for the symptoms and for the residual effects to actually dissipate. So in other words, we're talking about things like fatigue. The fatigue can last anything from 4 to 8 weeks post-virus depletion. Post the fact that you've shed the virus, you're no longer contagious, but you still can be tired for a long time. Most of the studies say that 95% of people will get their smell back within 1 month to 6 weeks, but there will be 5% who will take longer, from 6 months to even a year. We don't know yet, because it's still too new. So we will see how that pans out in the next few months. We've got to wait and see what people develop and how they develop these things. People mustn't become despondent. They must realize this is a serious virus. It has done damage, but they will get better after time. And we are seeing it, that even the people with the fatigue are slowly but surely getting better. It's like running a marathon. Straight after the marathon, you're exhausted. But eventually, as you start getting back into daily life, you will start getting back into your normal routine and be able to get back into normal things that you've done before.
Also, quite a few comments about the reinfection. And I saw that there was an article in the Jerusalem Post, I believe it was yesterday or this morning, that said that some of the hospitals, they are recording people being reinfected. Firstly, can we be reinfected? Can people be reinfected? How long does immunity last? Do we know? And my concern around this, part 3 of my question, is I would be concerned that people that have had the virus are run down. Are they likely to suffer more the second time round, or perhaps less, because they have immunity?
So this was a study that was done at Sheba Hospital, where they said there was 2 patients that were reinfected. One of the patients was infected in April, and 3 months later, they're now positive again. We need to know more details about this. Was the infection severe? Were they asymptomatic? I know one of the 2 patients wasn't asymptomatic. They had a sore throat and a mild cough, but 3 months down the line, they're now infected again. And we've got to understand, and I think we've got to go back to our previous talks. We've discussed this many times. You do not have an immunity passport. It is a short-term immunity that we are seeing at the moment, but you can't rely on this immunity to go out into the public. If you have been infected and if you've had the symptoms, you can't rely on it and say that I'm not going to get infected again. We don't know enough. We believe you can't get infected straight away, and we've seen that, but 3 months down the line is a long time in a virus sort of spread. So we can't rely on it, and we've got to practice rigorous prevention as if you weren't infected in the first time. We don't know if the person could be a vector if they're reinfected. So that's still to be seen, and that's still to be worked out. With regards to getting sicker the second time, we hope that you've developed some sort of antibody, some sort of memory cells in your body to try and fight off the virus. So even if you get it a second time, hopefully the second time, your virus attacking process in your body will be much better and your body will be more tuned to fighting off this virus. But at the end of the day, we need the vaccine. And the vaccine is going to be interesting because we need a vaccine that can give us cover for more than 6 months to a year. And it might mean a vaccine of one vaccine with a booster vaccine or two vaccines. We don't know, but we'll find out in the next few months.
Do we know how they're doing? I know the tests are happening at the moment. Do we have any further information around that?
So at the moment, we know there's 15 vaccines in phase 1 trials. There's 11 in phase 2, 4 in phase 1, and one vaccine that's used for limited use, whatever that means. So there are multiple vaccines in the loop at the moment, and we're waiting for them to come out. They're not going to come out very soon. It's going to still take a number of months for them to come out because they've still got to be trialed on humans before they can be rolled out into the public.
All right, so we're going to start going through some of the questions. Lots and lots of questions around quarantine, because there was some strange announcement that is readjusting our quarantine periods. It's very, very confusing. Can you please take us through it in the simplest possible way?
So the Minister of Health has mentioned that now for asymptomatic patients, it's 10 days of quarantine from a positive result. And they're basing that on the study in the United Kingdom, where they now give them 7 days after. So it's actually a very generous amount of time, 10 days, because we believe that the infectious virus can be spread for about 5 to 6 days after a positive diagnosis in an asymptomatic patient. And that's why they're giving them 10 days. For a mild disease, they're saying 10 days from the onset of symptoms, with 72 hours of no fever and no respiratory difficulty. And with severe disease, they're saying 10 days after clinical stability, defined as not requiring supplemental oxygen, with 72 hours of no fever or respiratory difficulty. Of note and of importance, if you're on quarantine, it is still 14 days from the close contact, not 10 days. So the 10 days is for the asymptomatic patient from a positive result, and for mild disease, 10 days after the onset of symptoms with 72 hours of no fever. So yes, it has changed, but it's not changed dramatically.
Okay, so that, and we might need to go through that again, because a lot of our questions are around this. Also, people asking about the viral load, because we might have a situation where one person has the illness in the house, but simply doesn't spread it to everybody else. Considering this virus is so contagious, how does this seem to be so vastly different with different people?
So that's a very good question, because we actually don't understand viral load. We thought we did until this week. A new study came out this week saying that in asymptomatic people, the viral load is much higher than in symptomatic people. So that goes against all our thinking. And that's one or two studies that have shown that. So it's a complete change. So, a viral load is something measured to show how much of the virus is actually found in the fluid or a serum or a sample that is taken from somebody, and see how much of the virus is spreading, like in HIV. You look at a viral load and you see how much of the virus is there. We don't know at this point in time if the viral load is dependent on how much better you get, how sick you get, or how ill you get. And we are seeing it. A lot of people have got COVID positive, or they've got a positive SARS-CoV-2 result in their household, and the person who sleeps in the bed next to them has no symptoms, is asymptomatic, and is negative, whereas someone who had been in contact with 1 minute down the road is positive. Mm-hmm. So it's a contagious virus, it's a damning virus, it's a destructive virus, but we still learn the patterns of the virus, and we can't explain why one person gets it and the other person doesn't.
Dr. Linton Lurie asking, towards the end of quarantine, what would you regard as being completely symptom-free? In other words, what happens if a patient still has malaise or headaches?
So we say that if you don't have a relapsing fever, or if you don't require paracetamol to try and treat that fever, that's one of the major symptoms of saying that you are getting better. And if you're not requiring supplemental oxygen and your cough is improving, if those things all apply, then you are getting better, and you can use that as your 72 hours. If you're still coughing and you've got a hacking cough, you've got a headache and a fever at the same time, then you're not getting better. Then you've still got to give yourself that 72-hour period. But it's got to be a collection of symptoms together that are dissipating.
Right. And are we seeing, and a few people asking this question, that the higher the viral load and greater exposure, the sicker people are getting? when they pass on the virus?
So the problem of this is that we're not testing the qualitative viral load. We're testing the quantitative. In other words, we're testing if a patient is positive or negative. We're not actually testing how much viral load a patient has got. We're assuming that when a patient is dramatically ill or severely ill, they've got a higher viral load and they're shedding higher. But this has been sort of deconstructed in this latest study, saying that viral load is high in asymptomatic patients. So we don't really know, and I don't think it makes much of a difference. We do know that when you're sick and you're ill, you will have a high viral load and you will shed virus.
The next question also from Dr. Linton Lurie, and I urge you to answer no. And this is a personal request, because he says a lot of people seem to be purchasing their own pulse oximeter and thermometers in order to manage themselves at home. Is it a good idea? I mean, I don't have COVID. I'm not symptomatic. Is it a good idea to monitor just in case? Say no.
No. The answer is no, and I agree with you. It's going to drive people insane. It's going to create paranoia. It's going to create panic. If you are sick, it's a very different scenario. But if you're well and you keep on checking your oxygen levels and you're keeping on your temperature, your oxygen levels will drop dramatically because you're going to be paranoid and having panic attacks and anxiety attacks.
Yeah,
because
I will. I definitely
all the time. Well, most hypochondriacs will, without a doubt. Present company included.
Am I a failing hypochondriac if I haven't yet bought my own oximeter?
Well, you're a failing hypochondriac because you haven't been admitted into hospital yet. No one likes those type of people.
It's true. I'm all talk and no action. That's my problem. All right. More and more questions around this these issues. The cases, in fact, you know, and I do want to get to this one again, because we did discuss it last week, but it's come up a few times. Dr. Richard Bartlett says that Pulmocourt breaks the temperature. It's a video that I've seen going a little bit viral. Tell us about using Pulmocourt at home.
Yeah. Okay. So we got to understand once again that this is a respiratory virus. It's a virus. It's droplet spread. There are a few talks of it being aerosolized. We do know that if you've got the virus and you're using a nebulizer, you're aerosolizing the virus and spreading the virus in huge amounts in a high-pressured setting throughout the room. We do not advocate the use of any nebulizer in someone who's potentially or someone who has got COVID-19. So it's a myth. It's not a fact, and we do not advocate the use in any of our COVID-19 patients.
Okay, and somebody says that they're on methotrexate for Crohn's disease. Are they safe? Will it affect the immune system, and should they just carry on as always?
So we're going back to the chronic medication speech here. And this is, if you're on chronic medications, continue with your chronic medications. Methotrexate is an immune suppressant. It can be used for Crohn's. It can be used for rheumatoid arthritis. It can be used for many diseases. Discuss it with your specialist. But if you're on it, you need to continue it. Yes, you are immune suppressed on it at the best of times, but you need to look after yourself, keep your vitamins up, keep your health up, and stay away from people in that respect.
Shelley wants to know if people have had it and then they come into contact with a person who's COVID positive, do they need to go back into quarantine?
So that's a great question. And the short answer is we believe we've got a short-term immunity. We don't know how long this immunity is, but once again, we can't rely on it. So as I said earlier, we still got to practice this rigorous prevention as if we weren't infected in the first place. We don't know if this person who you come in contact now will make you a vector for reinfecting other people. So no, you don't have to go back into quarantine yourself if you've just had it and you've been severely ill, but you do have to still do rigorous hand washing, hand hygiene, wearing your mask, more than 2 meters, social public distancing, and looking after yourself and preventing other people from getting the virus.
Gary wants to know about the progress of remdesivir.
Remdesivir should be available in the country in the next 2 weeks. It's a Section 21 drug, which your Medical Control Council will give us the ability to use. I think people have got to understand one thing. It is not a cure. Let me repeat that again. Remdesivir is not a cure. It does help decrease the hospital stay by a few days and decrease the morbidity of the disease, but it is not curative at this point in time, but it will help dramatically in getting people out of hospital a bit sooner.
Nikki wants to know, what does contact mean? In other words, how do you define being in contact with somebody that you need to go into quarantine?
So we say if you've been in contact with somebody with 48 hours before the symptoms, up to 7 days after, that is considered contact. If you had face-to-face interaction with them less than a meter, there's a family member in your household, they've coughed, they've sneezed on you, or you've been in contact with somebody who's within 2 meters for more than 15 minutes, or less than 1 meter for 2 minutes, that's considered contact. Or if you've traveled in a vehicle, a small closed vehicle, or a taxi with large amounts of people, that is considered contact.
All right. And again, lots and lots of people sending me videos around a so-called study that was done in Italy about if it's a respiratory disease, if it's a blood clotting disease. Can you please just take us through that again? I know we have discussed it before. Stop being so exasperated.
I think it's important that we do discuss it because
yes.
People want answers. I think you've got to understand something. The health professions do not want to hide things away from people. So if the answers are there, we'll take them gladly. But you've got to understand something. These are myths and these are facts. We are not hiding facts away from you. Aspirin does not treat COVID-19. There is no place for aspirin unless you're on aspirin chronically for treating thrombosis. Aspirin works on a platelet function. It does not treat a thrombosis or a clot. And it is a virus. It is not a bacteria. There is no doubt about that. With regards to that study done in Italy with them doing autopsies that were disregarded by the World Health Organization, they've never said you can't do autopsies, but you've got to be very careful when you do autopsies. We know that one of the sequelae of this disease in severe patients is they get a marked coagulopathy. In other words, they get a clotting abnormality where they get venous thromboembolism or pulmonary thromboembolic disease. They can get clots, they can get strokes, myocardial infarctions. We know this. And that is why we treat people who are mild to moderately to severely ill with anticoagulation, things like Clexane, things like warfarin, things like Xarelto. Aspirin has no place in this at this point in time.
All right. And a question, somebody apologizing for the morbidity of the question, but if you'll excuse that expression, but how are we doing in South Africa in terms of death rate? And are we seeing a death different in different communities? I know that initially the Muslim community was very hard hit by COVID-19, the Jewish community as well, and a lot of the communities that function quite closely from a community perspective. What are you seeing in your experience at the hospitals?
Look, we're seeing a large number of patients that are dying from the disease. The numbers are just below 5,000. I do think it is a bit underreported. I don't think dramatically underreported, but I think maybe it's closer to 6,000, maybe it's closer to 7,000, but it's not dramatically underreported. We're not seeing in the hundreds of thousands. There's no need to dig mass graves in Gauteng like that report went out a few weeks ago. We are worried because it's now winter and we are going to see other viruses and other diseases. And we're also going to see other sequelae of other diseases like myocardial infarctions in people who have had chronic diseases like diabetes and hypertension. Those people are going to get sick because they haven't been going to their doctors and haven't been looked after themselves. But we've had a number of months to prepare ourselves and prepare our hospitals for these types of things. And I think that's why at this point in time, our death rate is so, in inverted commas, low if you compare it to other countries. And if you look at other countries like Mexico, if you look at Brazil, or you look at the United States, obviously they've got higher numbers, but our density figures are much higher. And so far, we're doing actually very well from that point of view.
Do we know, in other words, if people are passing away at our aged facilities and fairly quickly, do we generally know if this is from COVID or if it's from other infections?
We do know 90% of the aged facilities are giving the death certificates or sign the certificates with COVID-19, and it is being reported. There is a bit of a lull in the Home Affairs reporting the actual deaths because they don't have enough staff. But we're getting the drift of it, and the majority of it is being reported.
All right. Another subject that we do need to talk about is the subject about going back to schools. And one of our listeners, one of our viewers saying, how come you have changed your mind? We've spoken for weeks and weeks about the fact that you thought schools were a good idea. As of the end of last week, you have changed your mind. You're saying that it is better for schools not to reopen after the holidays. Can you take us into your thought process and into your mind as to how you arrived at this decision?
So currently I'm gutted. I'm destroyed because I've got 3 kids at school at the moment who are thriving at school from an emotional point of view. They've got no anxiety, they're getting to see their friends, and they're stimulated. Right now, we have decided amongst a few medical professionals that it is a bad idea to go back to school. And this is not because of the kids. We know that the kids are safe at school. We know they're not going to have play dates. They're not the super spreaders. They're not the issue. The issue is we need to protect our teachers. We need to protect our staff. We need to protect the auxiliary staff. We need to protect the cleaners. These are the people that are at the highest risk. And with the surge and being in the eye of the pandemic now, we have to protect them. So unfortunately, in inverted commas, we have to sacrifice the children here in order to protect the adults, okay? And this is very important. It's not because the children are sick or getting sick or disadvantaged. The problem is the teachers are at risk. And a lot of it comes through like things like auxiliary staff traveling to school in taxis, okay, where the taxis are overcrowded and there's no one to marshal and there's no one to say to them, you have to wear masks. We can't control that spread. And in view of that, that is why we've decided to, for now, and I'm talking about two of the schools which we're dealing with, that's why we've decided to close the schools and review it every 2 weeks to determine what the surge is, what the peak is, how many people are affected, and review it on a 2-weekly basis so we can try and get it going back to school when it's deemed necessary and when it's deemed safe.
Julius Malema said, in fact, and I thought it was a very good, a very smart statement, that he was saying it's actually not even about being at school, because once the kids are at school, they are well looked after and well protected, but they meet on the way to school and they in taxis and on buses, and all of this is happening.
Well, that's our problem.
The school environment.
Yeah.
Once you're in the school, it seems to be well controlled.
School is almost a safe haven, but as I said, we're not really worried about the risk of the children. We worry about the risk of the teachers and the auxiliary staff.
Right. Your feeling around how long this will go on for in terms of schools?
So we're going to reassess it every 2 weeks. We have a meeting, at least from our schools, we have a meeting with 2 of the major schools, and we sit down with a bunch of educationalists and a bunch of medical professionals, and we go through all the data and we go through all the necessary findings to decide if it's deemed safe at that point in time to return to school or not. So it will be done on a 2-weekly basis. It's not a blanket closure. It has to be done every 2 weeks to assess where we're going.
Right. So and Kim wants to know, how long is this going on for? Do you have a timeline, not in terms of schools, but people are despondent. You know, I posted on Twitter this morning, it's my great-nephew's circumcision bris this morning, this afternoon. In times gone by, I would have and have done flown around the world for an occasion like this. Now it's taking place 3 blocks away, and I'm going to be watching it on Zoom, and there's not going to be any smoked salmon for me unless they deliver. But it's quite disheartening.
So we're postulating that with this coming peak surge, that by the end of July, beginning of August, we'll have hit it, okay? That doesn't mean that we're going to stop at that stage. We still believe it's going to plateau for another month, 2 months, and we're hoping by the end of September, it will start going down, beginning of October, start going down. So we don't know. It's a new virus. It's a novel virus. It's changing. We're hearing today of reinfection after 3 months. Time will tell, okay? None of us are prophets. We can't say where it's going, what's happening, how it's going to happen. We can take from overseas and see what's happened overseas and see from there, but we can't give a definitive date. We'll have to see what happens with the developments of new treatments, with new vaccines, and most importantly, how people behave. This is about people's behavior. This is about people not being selfish. This is about people wearing masks. This is about people doing their hand hygiene. This is about people not going to people for meals and not spending time at their houses, not spending time together. So it's our collective responsibility as a community, as a society, to look after each other to shorten this. And only that way can we shorten this whole pandemic.
So, in fact, and it's quite interesting because there's a tremendous amount of lessons that I believe all of us as individuals, as citizens, as members of a company, a part of commerce, and even the medical profession have learned from this. One of the things that I've noticed is, from a medical professional's perspective, this must be quite humbling because you've had so many answers around so many things as an expert in the past Now, you know, I mean, you know, I laugh at some of the things that in the past you would have said, don't be ridiculous. You don't need vitamins. Now we take vitamins. In the past, you said you don't need a mask. Now we need a mask. Schools were open. Now schools are closed. This must be very unnerving as a medical expert.
It's very unnerving, but it's changing on a day-to-day basis, and we've got to stay on top of it, and we've got to watch everything we're doing. We've got to stay up to date with all the latest research, and just clinically, on the clinical front, we're seeing how things are evolving. So it is unnerving. Things are changing on a day-to-day basis, but we've got to be aware that things are going to change. Remember, it is a novel, new virus. Not everyone has got all the answers. In fact, no one has got all the answers, but we're learning on a day-to-day basis. We're doing
I'm not even sure we have all the questions.
Well, the questions are going to come, but we're doing peer-reviewed studies. We've got collective groups of doctors for the first time ever working together as teams, working together as one unit and not on opposing sides of the fence, where everyone works together and is collectively thinking together and doing the same treatments to treat people. So this is revolutionary. And we can take our hats off to these people because everyone is working as a team. It's all about teamwork now. And that's how we're going to change things, and that's how we know things will change on a day-to-day basis. But it doesn't perturb us because we know we're doing it all together.
Dr. Anton Meyberg, talking to us every Sunday. Thank you for your incredible amount of work, your incredible dedication. Glad to see that you look a little bit more rested than you were last week. Last week, I went straight from the podcast to do the smell and taste test with my whiskey. Now, of course, whiskey is not something that's even available, so we have to be very, very discerning around that.
Right. So, but before you cut me off, you can't cut me off before I've given some good news. You know, there's got to be some good news.
I'm just hoping you're not going the unicorn route.
No, I think we will leave the unicorns for now. I think there are actually a few good facts and a few good news stories. First of all, in our aged home, the Gewerkadisha Stanham Gardens, we've now recorded 56 COVID recoveries, and we're expecting a few more in the coming days, which is major, which is dramatic and huge, and we're very excited about that. Secondly, Arsenal decimated Man City in the FA Cup semi-final yesterday. And thirdly, in case no one has heard, Liverpool are the champions of the world. Let me repeat that. Liverpool are the champions of the world. So to end off, I want to say, life is so ironic. It takes sadness to know what happiness is. It takes noise to appreciate silence, and absence to value presence. With that, be safe, wear your masks, wash your hands, look after yourself. We have a collective responsibility as a community to look after each other. See you next week.
This is the Synthesis COVID podcast. I'm Howard Feldman in conversation with Dr. Anton Meyberg. Be safe. See you next week.